So today's day chair, Mark Davis, is part of the fabric of this club. Mark joined Seattle Rotary in August of 1985, so he recently celebrated his 30th year with us. Apparently his dad told him to keep perfect attendance, and that is exactly what he has done. Mark, great to have you here today.
Thank you, Sue. You know, we don't talk about perfect attendance that often, so thank you for bringing that up. What one person can't do, and we've heard Paul Shoemaker talk about that, and what happens when one person can't not do something is they change the world, and Julie Lewis is changing the world. But others that come to mind in our club that I can think about are Bill Gates with polio, Geraldine Bruchot with Vietnam, Nancy Slater with malaria, Dan Evans with public policy. And in 2014, when I saw Julie speak to the Women of the World breakfast in Seattle and keynoted that address, it became very clear to me that the person who's leading this effort for AIDS is Julie Lewis. So without spending any more time on her introduction, I thought it'd be best for Macklemore to do the honor.
I'm Ryan Lewis. I'm a music producer and a film director. As you can see, the past couple of years of my life have been absolutely crazy. Everything I knew of life completely changed in an instant. I worked for years on an album with Macklemore that would take us far beyond what we ever imagined. Before I knew it, we were constantly traveling. We played roughly 300 shows in a single year. We heard songs that we made in our parents' basements, played on every radio station in the country. We walked on red carpets and did hundreds of interviews. Our music had exploded into the world. But that is my music story. That's a story you may have already heard, so let's rewind. What a lot of people don't know about me is my life before Macklemore and Ryan Lewis. A huge part of what's made me who I am is something I haven't talked about in interviews. If I could steal just a few minutes of your time, I'd love to tell you about the strongest woman that I know, my mom, Julie Lewis. In 1984, my mom gave birth to my oldest sister, Teresa. In Washington State, this was 1 year before anyone was testing for the HIV, AIDS virus, and blood donations. After giving birth, my mom ended up needing a blood transfusion, and without anyone knowing it in that moment, had HIV-positive blood put into her body. At age 25, 1 year younger than I am right now, her life would change forever.
For years, my mom had no idea that she had HIV. She gave birth to my sister Laura and my brother Ryan and just continued living her life. She started to feel unusually sick and went to the doctor multiple times and was finally diagnosed as HIV positive, and in turn was given only a few years to live.
My brother and I were not born with HIV. We both had a 25% chance of being born HIV positive, but we weren't. We were both extremely lucky.
My name is Julie Lewis, and I'm HIV positive. I was infected with HIV 30 years ago. And I never thought I would be sitting here 30 years later talking to you. I was diagnosed HIV positive in the summer of 1990. I was 32 years old, and I had 3 young children. They were 2, 4, and 6 years old. I had never thought about dying.
But you know what's amazing? My mom never died. She lived.
She never thought, and we never thought as a family, that she would be a 30-year survivor. So for her, coming up with this idea of how do we celebrate in a way that can have a positive impact in the lives of other women, girls, families around the world who didn't have the access to the kind of healthcare opportunities that she has had.
I want to do something big. The 30/30 Project is that big idea. We believe that healthcare is a human right. We have the knowledge and we have the treatments. Life-threatening diseases like HIV/AIDS can be managed. What people need is access.
In celebrating this 30-year mark, we want to provide just that, access to healthcare for those who need it the most. We want to build medical centers worldwide that will stand strong for at least 30 years. It's called the 30/30 Project. So how are we going to do this? First, we bring in Construction for Change to build the building. Construction for Change architects then draft a blueprint. A project manager is sent to the site. Local foremen and community workers are hired to build the structure. Local partners like Partners in Health fill the building with doctors, nurses, and healthcare specialists that begin working immediately. Suddenly, comprehensive healthcare, meaning healthcare that covers all illnesses, is available to the entire surrounding community of 20,000 people. The first destination is Malawi. Why? It's a no-brainer. Over 1 in 10 adults living in Malawi has HIV or AIDS. There's an immediate need for the exact type of medical center that we're talking about in the rural Nino district. Let's talk bigger picture. Imagine 30 of these medical centers popped up all over the world. What would that provide? Roughly 600,000 people would now have access to healthcare. With this amazing past year that I've had, I'm honored to be the first donor to the 30/30 Project. I'm asking you to join me. Join my family's story. See how far we can take this. Malawi is only the beginning. There are so many locations in need of medical centers just like these ones.
Well, hello. First of all, I just want to really thank Rabbi Weiner for that prayer. That was very special and dear to my heart. And also thank you, Mark, for your kind introduction. Well, I have never been a Rotarian, I must confess. But my father and my father-in-law were members of the Rotary Club most of their adult lives. And so I've heard a lot about Rotary's programs, and I've always been very impressed, in particular around their work in global healthcare, around the eradication of polio. This year, with the new global goals, UNAIDS has put out the mandate to end AIDS by the year 2030. And I have to say, for me, that's kind of a daunting task. And yet I have to stop and think, if you are almost there with polio, then why not AIDS? And so thank you for all your work and for that inspiration. Well, I have been HIV positive now for 32 years. 32 years is a long time, roughly 12,000 days, having now taken about 60,000 pills to stay alive. Let me tell you that 32 years is a very long time. Well, I want to transport you back in time today to the early 1990s, long before Macklemore and Ryan Lewis. I was just a young mom with AIDS. Having been given 3 to 5 years to live, I joined a speakers bureau with about 15 other HIV positive people. And we went to schools and universities, drug treatment centers, just really pretty much anywhere that would have us to talk about HIV. You know, I joined the Speakers Bureau for purely selfish reasons. You see, I had 3 little children, and I was really afraid that my very own kids would suffer stigma and discrimination because of a disease that I had. I really wanted everyone to know that this wasn't a disease that was caught. You didn't catch AIDS. It was acquired. There were definite ways to acquire it. You didn't need to acquire it, and you didn't need to be afraid of the people who had it. The fear was very real, though, and I experienced it the most within the healthcare community from the very people who were there to keep me well. I once had a lab technician ask me to swab my own throat because they didn't want to get that close to me. I went into the emergency room once with appendicitis, and 12 hours later, after my appendix had ruptured, did they finally find a surgeon who was willing to operate on an HIV-positive person. My friend Shirley once said to me, "Let's just pretend it's cancer." You know, I think cancer is horrible. But I've never had a friend with cancer who had someone say to them, "Let's just pretend it's AIDS." I was on that speakers bureau for 10 years, educating my community in hopes to lessen the fear that surrounded this disease. But as I started to learn about healthcare for the extreme poor around the world, my stories compared to their stories seemed more like inconvenience and ignorance. Because you see, at the end of the day, I got healthcare. I had doctors. I got medicine. I had health insurance. And I had a car to take me to those appointments. When my family first told me that they wanted to do something to commemorate my 30 years of living HIV positive, I knew immediately that I wanted it to be some kind of pay it forward kind of project that did something good for someone else in honor of all my friends who had died of AIDS. Well, I had been volunteering for Construction for Change. Construction for Change is a nonprofit construction management organization that provides infrastructure needs and expertise to other organizations working around the world on behalf of the poor, usually in communities that lack resources. Well, I was at an event for Construction for Change where one of our project managers was talking about a hospital that CFC had built in northern India. Now, my volunteer job at Construction for Change was that I received the applications and I vetted the organizations who we partnered with. And I had been one that was a big fan of this organization where we built the hospital. I also got weekly updates for about 6 months about this very hospital being built. But it wasn't until I was at this event and one of our project managers was showing this slideshow. Did it follow? Come on, help. There we go. Uh-oh, did it go to, okay. Okay, there we go. This slideshow, that I realized this hospital was primarily built by women. There they were, these Indian women in their long Indian sari dresses, with cement bags on their heads and tools in their hands, building a hospital. Well, Martha, our project manager, went on to explain that although CFC pays a fair wage, these women weren't primarily motivated by money. These women were building a hospital because they were tired of their very own children dying en route to the nearest medical facility, which was hours and hours away. Many times they would only get there to be turned away at the door because they couldn't pay. Well, I looked at my coworker, Jenny, and I said, if those women can do that, then we can do more. We can just do so much more. I decided that I wanted to help provide healthcare access to people and families around the world who didn't have it, like these women in India. We launched the 3030 project a little over a year and a half ago with Construction for Change and the Macklemore and Ryan Lewis team. Our goal is to build 30 healthcare facilities in places that lack healthcare access. To date, we are building our 5th clinic. We have funding to build 7, and our goal is to raise enough funds to build 10 by our 2nd anniversary this April, which would put us a third of the way to our goal of 30. In the movie, by the way, that video Ryan made when we launched the project a year and a half ago, and the clinic that we talked about that we were going to build for Partners in Health in the Nino district of Malawi, well, there it is. I think they moved the furniture, the medical equipment and stuff in a couple weeks ago, and it should be open now. So it's a really cool building. We're really proud of it. So there's that. We are just so grateful to everyone who has supported this project and donated to this idea of providing health care. Well, today, really what I want to talk to you about is healthcare in 2 countries. A very large country, India, and a very small country, Togo. Well, if some of you have a hard time placing Togo on a map, don't feel bad. Almost everyone I talk to about Togo doesn't exactly know where it is. Togo is a small country in West Africa. It's lodged between Ghana and Benin, and Togo has been voted the last 3 years in a row as the saddest place on earth. We are hoping to help change that. The 3030 project is currently raising funds to renovate 4 government clinics in Togo and to build a very needed maternity ward. So what does it mean to renovate or remodel a clinic in Togo? Well, first of all, let's just talk about what it means to remodel something here, like your kitchen or my kitchen. You know, when we remodel something here, we basically replace things. We replace our sink because it's scratched, or we replace our appliances with stainless steel, or we replace the countertops with quartz or granite, or update the colors. Well, in Togo, when we're talking about renovating or remodeling a clinic, we're actually not talking about replacing things. We're talking about adding stuff. We're going to add electricity where there isn't any. We're going to add water and water access where there hasn't been any. We're going to add bathrooms so that the patients don't have to go in the neighbor's field. And we're going to add space so that line that wraps around the clinic from early morning to late at night with patients waiting can move a little faster so that their healthcare operations can be a little more efficient, and so that that line can maybe be under cover. Dang it. There. Okay, so those are the 4 buildings. You know, I've been reading applications and vetting projects for CFC for 5 years now. And I have to say, I have never received a more compelling application with photos and stories. To be honest, we don't usually renovate things. We build from the ground up. But this application was so moving. These are the 4 buildings that we're going to renovate. One of them is infested with bats. So can you imagine going for healthcare to a building that's actually that unsanitary? The crazy thing about this is that for about the same price that kitchen would cost you and me, about $25,000 to $35,000, we can renovate one of these buildings. These buildings literally save lives and change lives. Well, let's talk about India now, healthcare in India. You know, in India, you can get some of the best healthcare in the world, unless you're poor. And then I'll almost guarantee you that you're going to get some of the worst. The 3030 Project, Construction for Change, and a nonprofit called Optimize Health are banding together to build several government health clinics in one of the poorest areas of India, the state of Madhya Pradesh. Each one of these, well, we're just finishing our first health clinic. It should be done in maybe a month or two. It's our pilot project. And each clinic that we're planning to build there is about $125,000. So recently, I was included on an email chain that gave me just a glimpse of what it means to be poor and sick in India. This email was about Stuti. There's a picture of Stuti. Stuti is a 14-year-old living in Delhi. And Stuti has multi-drug resistant tuberculosis in her spine, otherwise known as pot spine. Well, this email was long and intense, and it highlighted in bullet points the last 50 days of Stuti's life, being transferred in and out of medical facilities 14 times. Many times she was just met at the door by armed guards who wouldn't let her in because Stuti is poor and can't pay. One time they admitted her into a hospital only to kick her out the next morning because they said there were other people who had a better chance of surviving than she did. Stuti needed at least 2 surgeries and was failing quickly. But what caught my attention most in this email chain was the very last bullet point. The last bullet point said, Stuti aspires to be a police officer. Stuti aspires to be a police officer. You know, if you were to ask me what the 3030 Project is really about, it's about Stuti and the millions of Stutis around the world who have aspirations, who have dreams, and against all odds, have hopes for their future. Stuti has not lost her imagination, so I must not lose mine. I imagine a world where a person's health isn't dependent on where they live or on how much money they have. You know, these healthcare buildings that we build, these buildings are so much more than buildings. I mean, sure, they provide comprehensive health care, but they also provide vaccinations and preventative disease education, so people don't even need to get sick. They provide primary care, so someone who first gets symptoms can walk to somewhere in their own community and get health care, instead of waiting until that little thing becomes a giant fatal disease. These buildings have a ripple effect that provide economic opportunities and employment in these communities. Not just employment in the clinic, but we hire a large construction crew and foremen to build these buildings. The ripples go further. You know, sometimes these buildings are the only place that have electricity in their communities. One of the clinics we built actually ran a line from their generator under the freeway to the local school, so the school now has light. I was in Kenya last summer, and a man came up to me, and he said, "You're now my children's mother." Okay, I've never had a weirder thing said to me in my whole life, I'm gonna be honest. And I said, "Please explain." And he said, well, my wife died of AIDS, and I was unemployed, so we couldn't pay the school fees. So my children weren't in school. But I was lucky to get hired to be on the construction crew for this new clinic. And now I've been hired to be the groundskeeper, and so my children are back in school. These buildings are way more than just buildings. Stuti aspires to be a police officer. She hasn't lost her imagination, so let's not lose ours. Please consider joining with the 3030 Project as we seek to provide health care in places that really don't have any, especially for the poor in their communities. You know, we have a pipeline of places we could go. We have a lot of organizations who have gotten a hold of us, who are doing great healthcare work, but if they had infrastructure, they could increase their capacity, their outreach, and their quality of care. We're ready to go to a lot of places, but what we need is funding. So please consider joining with us in providing that health care and in believing that health care is a human right. Thank you. Okay. I guess we're having questions. And you know, I have with me Teresa Hillis, who's the director of the 3030 Project, and Kelsey Wood, who is the executive director of Construction for Change. So I actually might defer one of these questions or a couple of them to them. We also have our director of operations, Tim Hickory, who is the building expert. So I don't know everything. That's all I'm saying.
Thank you for your comments and your efforts. Many of Rotary's international projects are jointly done with local clubs in the foreign countries that we are helping. Are there any Rotary clubs in any of these areas that you're focusing?
We have not partnered with Rotary internationally. We are totally open to doing that. So if you want to help us with that, we'd be grateful. So.
I want to follow up on that question. There are 10 or 11, I've forgotten how many clubs in Togo.
Exciting.
Four or five of them around Lomé. So that's a great partnership to engage in for the kinds of projects that you're doing. And with those international partners, we can leverage Rotary funding and local Rotary Club sponsorship here in our district to help you realize with the Rotarians there these kinds of health projects.
That's awesome. If any of you want to form a little club to be our champions on that, we would gladly help us in any way.
Julie, earlier in the year we heard from some of the leading experts on breast cancer and their work that they were doing in Africa and how the stigma of breast cancer precludes people from getting treatment early on. And oftentimes women will wait until they're nearly dead as a result of it. How are some of the diseases, AIDS and things of that, what have you seen as far as people's willingness to go get treatment in the community?
Well, I mean, with HIV and AIDS, there's still a lot of stigma here, to be honest. I mean, I don't know if any of you follow stuff on Twitter, but when Charlie Sheen came out HIV positive a few months ago, which, you know, Charlie has a very colorful life. So there was a lot of comments, but the fear comments around HIV that you might have expected in 1985, it was just shocking. You know, when people can hide behind the computer, it's amazing what they say. And I was genuinely just I was stunned that in the US, these would be the kinds of comments that came out. And I thought, wow, if I hadn't disclosed my HIV status and I was reading this, I wouldn't. It's just too scary. But if you go to somewhere, like when we were in Kenya this summer, different places in Africa still, the stigma is so great. People get kicked out of their communities. People have their families abandon them. Stories that you might have heard here at the onset of HIV and AIDS, people still don't understand that it's an acquired disease and they're still fearful of getting it in ways like sharing utensils, eating, things like that. I think the big push with the whole goal of ending AIDS by the year 2030, you know, we've had great progress in internationally in lessening mother-to-child transmission. There's no reason a child should be born with AIDS. There's medicine that will make that just almost an impossible thing. But if people can't get the medicine, there's still children getting infected. The thing is that people need educated. You know, there's still all of this fear and stigma because they're not getting good information. And like I was saying, we've made great headway, but the last 20% of something is really hard. Like finding that last 20% of people who are at risk of getting HIV or who are HIV positive and need to be on treatment, because if you're on treatment, your chance of passing that virus to someone else goes way down. You just have less virus in your body if you're on treatment to pass on. So what we're looking for, you know, the whole PEPFAR, the president's emergency plan to fight AIDS that Bush started, and it's still there. It's kind of our big international effort, and UNAIDS. They're now not focusing on countries. They're focusing on communities in those countries that have a high risk. They're also focusing on different populations, like young people are still really at risk. The numbers are real high for various reasons. One is education. One is that kids just don't think they're ever going to get anything. You know, they take a lot. They're big risk takers. So anyway, that was a long-winded answer to your question. But basically, around the world, there is a global effort, and they're looking at some of the countries that have had violence, like the Democratic Republic of the Congo has real high HIV, and their populations are actually really young because they've had wars. So they're focusing on these hard to go, hard to be in countries, because that's actually where the last 20% or 10% of HIV is, right? I mean, it is in other places, but it's growing in those places, so.
Great.
Julie,
Yeah.
thank you so much for your leadership, your inspiration. And I want to take advantage of your Speakers Bureau experience and ask you a direct personal question, which would
Yeah.
certainly be educational to me, so I think it'll be educational to some of the other folks here as well. First of all, do current AIDS patients, new AIDS patients in the United States have much difficulty with insurance coverage? And also, how about the expense of the drug regimen that you have to undergo? And, you know, how is that all working out for new and continuing AIDS patients here in the United States?
Okay, well, it's been about 10 years since I've actually worked professionally. I used to work at the health department as an HIV/AIDS educator. So I'm just going to talk about my own personal experience. I also have an HIV positive brother, so I'll talk about his experience. There are programs in the U.S. that supplement health care for HIV positive people. There's the drug assistance plan that the federal government has that whether or not you have insurance, it pays the part that you owe. So there is supplements to your healthcare policies. There's services. There should not be anyone with HIV who can't get medicine in the U.S. There is. I mean, I'm going to tell you there is, but there shouldn't be. There are services and plans for that. The problem in the U.S. with so many things, this is my opinion, personal opinion, whether you're applying for college now or whatever you're doing, is the system is so freaking complicated that if your life is already kind of messed up, and maybe HIV is not in your top 10 biggest problems, but you happen to be HIV positive, it's just so complicated that you actually do need a case manager to figure it out for you. Plus, these systems change constantly. So just when you think you know it, it's changed. I mean, just anyone who has a complicated illness or a cancer, whatever, their biggest problem is figuring out how to get even their insurance company to pay for what they should be paying for. I mean, our healthcare system's complicated. That's all I have to say. And it's complicated, especially as a sick person, trying to take care of yourself and then navigate how to get it paid for. But short answer is there are those systems. They're just hard to navigate, in my opinion. So,
Question from Nancy Osborne.
Julie, I want to personally toast you because I was one of those individuals from between 1976 and 1980 that had over almost 20 transfusions connected with childbirth. I remember that fear. It's still palpable. And you have transformed that into something positive, something that is going forward. What you're doing is amazing. Thank you.
well, thank you.
Julie, could you tell us a little bit about how you identify the communities that are the places where your work would have the biggest impact, and or how do they find you if they are not a community that is necessarily on the world map or known about?
It's a great question. When we look for a partner, what I look for first of all, Construction for Change doesn't just build health buildings. They build community centers, they build schools, they build buildings that have the biggest impact on the largest number of people in an area of need. But we are their healthcare wing. And what I look for when I'm looking for a partnering organization is a healthcare provider who has been in the area for quite a long time, who's doing excellent healthcare work. We like it if they're partnering with the government health system, because really when you're talking about people in poverty, even though some of these government health systems are kind of broken, if you can at all get them to work, they're gonna work the best for people in poverty, and they're also going to work for the longest period of time. So we like partners like Partners in Health, who works directly with the government health ministry in the countries they're in. We look for organizations that have been serving the population where we're going for some time. For example, Partners in Health for the clinic that we built in Malawi had been taking medical mobile units, so they've been driving medical clinics into this area in Neno for some time. But then if you didn't get sick on Tuesday, then you were kind of screwed. And the roads were so bad that there were many days they couldn't make it up there because it's very remote. What was the second part of your question? Oh, how do they find us? There's kind of a few ways that we find partners. Usually they hear about us from somewhere and they apply. And we get applications, and then we go down the process of making a relationship with that partner and finding out if it is a good fit. There's some organizations that do great healthcare, but for some reason or other, it's just not a fit to work with us to build something. So we'll brainstorm with them other opportunities they might have. Sometimes we have, like Partners in Health. I actually went after Partners in Health. I just knew about them. I'm a big Paul Farmer fan from long ago. He's a well-known person in global health development. And I knew I wanted to launch the 3030 project working with them. And we are now in the process of setting up our second build with them. In that general area, there is a hospital that the people in Nino, if they got really sick, would go to this hospital. It's several hours away. But there's no outpatient clinic. So there's not that middle step between your local clinic and then the major hospital. So we're building an outpatient clinic for the hospital next. Yeah. So I think those are the two ways. I think the third way is that this is our least favorite way, I'm going to tell you, but this happens. Someone with a whole bunch of money wants to build something in Timbuktu because they went there once. And then we have this thing of like, okay, let's take this country and try to find some good work. And that's really the hardest way to set it up, and it's not our favorite way, but it's happened. So that's like the third way that we find a partner.
Hi, Julie. Thank you for your
Where are you?
service.
Who's talking?
Right here.
Oh, right there, okay.
Can you please tell us about your the people that work in the clinics, the doctors, the nurses, the staff? Are they pro bono? Do they get paid? Are they there permanently? Who pays for the medicine? Any out of pocket for the people that use the clinic?
Another great question. Because we partner with, we don't actually provide healthcare, we build buildings. Our partners all do it different ways. One thing that we require of every partner is that they never turn someone away because they can't pay. So they might have a sliding scale of fees, which is okay, but those fees are very low, and we just request, if we're going to build a healthcare facility for them, that they figure out some way to provide free healthcare for people who can't pay, because we don't want anyone to get turned away. And we all know that free healthcare isn't free, right? So this is a problem that they need to solve before we can build a building for them. And that problem is solved all kinds of creative ways. One of our clinics that we built in Kenya actually did a feasibility study in their community and found out that people would pay for a mortuary because there wasn't one. So they literally built a mortuary first and then built the clinic. And the mortuary is now paying like 90% of the fees of the clinic. Another applicant that we had a nursing school next to their clinic, and they train nurses, and the fees that they get from that school go to pay for the free healthcare. So, yeah, and sometimes you can connect with government programs, and the government programs will pay for the free healthcare that you provide to someone who can't pay, but it is a requirement because, you know, it really isn't healthcare access if it's only healthcare access for people who can pay. So, yeah.
Hi, Julie. Thanks you again for all that you're doing. It's really amazing, and I'm really proud of you. I think we all are. I had a question. Several years ago, I was reading an article about HIV/AIDS and its spread and the places where it's more prevalent than others and what have you. One of the issues, and I have a question for you, one of the issues in combating it was, in certain regions, was the cultural aspect of not necessarily coming forth and saying, I think I have HIV/AIDS, but the cultural aspect, which, for lack of a better phrase, cultures where the women don't necessarily have a choice as to who is going to rape them or have sex with them. So, and that's a cultural thing in those certain cultures. Has there been any advancements, i.e. improvement in those cultural thought processes in those countries?
Well, that's a big question. And women around the world often don't have the same choices that men have. And I think one of the movements among young people, especially, like, I've only been to a few countries, and when we were in Kenya last summer, the movement to empower young women to make their own decisions and to have the adults support that, it is happening, but when you have cultural norms that have been happening for generations, change is slow, right? So that's a really big question, and it really goes beyond HIV and AIDS to so many issues where women don't get to have choices. And you know, even we just, we being Construction for Change, just
partnered with an organization in Kenya. They needed a kitchen at their school. But what they do is they are a place for young women who don't want to get married when they're 12 or 13 to go, and they fight against female genital mutilation and some of the tribal practices that have just been happening for years, and giving young women other options. And sometimes their family brings them there just to get them out of the community during those years of their life. And along with that, this wonderful woman who runs the school, Priscilla, educates them and talks to them about their big future and how they can go to university and have dreams for their future instead of being married to a 40-year-old when they're 12. So these are just big issues that, you know, building a building will have a little impact on, but those are way bigger cultural things that I think we should all be aware of, and in any way help organizations that are working in those countries, especially community-based organizations that are from those places and understand the culture and the norms and have the most voice in the young people's lives. So.
Thanks for your courage. Has there been any effort to introduce PrEP into high-risk populations in Africa to reduce the transmission rates that we're seeing? In fact, I don't even know if a lot of people in the U.S. know about PrEP.
I can talk about
because I talk to people and they're like, they have no idea that even exists. But I wonder if that's something that you're also working on, and certainly that could help to reduce the incidence among high-risk populations.
Okay, so we have these things, these acronyms like everything, and one is PEP, which is pre-exposure prophylaxis. Post-exposure prophylaxis. So if you're a nurse and you get a needle stick, they give you medicine, post-infection possibly, and that should cut it down. Well, now they have a medication called Truvada, which is one of my regular medicines in my series of several pills I take a day. And Truvada has been shown that if you know you're going to be in a high-risk situation, say my husband, who's HIV negative, this is like way oversharing, but we still love each other. And so if he thinks that he might be in a risky situation, he could take Truvada. And it's shown that if you're in a discordant couple, that's what it's called when one of you is HIV positive and the other one isn't, that person can take Truvada, and it's shown to way decrease down to very small the chance that they would be infected with HIV. So in communities that people are engaging in high-risk activity, it's called PrEP, pre-exposure prophylaxis. That's what it means. So your question was, is there any headway internationally in some of these countries with using PrEP? A little bit. My question is there any headway other than, my big beef about these, like PrEP, is that I know a lot of men who have been talked to about going on PrEP, hardly any women. I feel like women don't get offered, even in the US, the same options as men. I've been going, I know about PrEP because I'm an AIDS educator. As many times as I go to a physician, no one has ever said, should your husband get on PrEP? And it kind of teased me off because I know a lot of men who they say, you're in a relationship, maybe your partner should have PrEP. So I think it's here as much as other places. I think we have a lot of medical options that women aren't offered, and it's irritating, to say the least. So.
I met Tim Tusink, a fellow Rotarian, in the fall of 2007. He was my introduction to Africa, a missionary physician in a small Ethiopian community challenged by HIV/AIDS. We visited an orphanage playground. I was taken aback by the joy of these children. Something distracted me, and to this day, I cannot remember what it was. But when I looked back, everyone was gone. The playground silent. I stood frozen, fearing I had been left behind. A tiny hand slipped into mine. A beautiful little girl with gigantic brown eyes in a rustic pink dress tugged at my hand. Her huge smile led me into a maze of corridors and eventually into a large room where my group stood at the other side. She skipped away, leaving me safe, slightly embarrassed, with an entirely fresh point of view. I thought we had come to impact their lives. Yet without hesitation, this one with so little touched mine.